I call to order the Public Hospital District Number 4, Kane County, Wednesday, December 6, 2017, a work study session. And would you please join me for the flag salute? I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Steve, I think we've got one item before that.
Okay. But the clerk like to take the roll, please.
President Norris?
Here.
Vice President Young?
Here.
Secretary Spikers?
Here.
Commissioner Herron?
Here.
Commissioner Pollard?
Here.
Thank you.
May I have a approval of the agenda? Is there a motion?
I make the motion.
A second. Is there any discussion?
Madam President, or Chair, I'd like to suggest that we always have an item called other on the meeting. I think Tom is going to check into this.
I have a call with Skip tomorrow.
Okay, thank you.
Okay.
No other comment.
All right. Shall we vote? All those in favor say aye.
Aye.
Aye. Oppose? Okay, that's unanimous. We now have public comment, and we do have some public. I don't know if anybody wants. Okay, we'll start there and go over that. No. This is not. He's not privileged because we know each other. Go ahead, Ken.
I'm going to be closest.
Yeah, makes it easy.
Good evening, Ken Koenigsmark. I live at 5713 285th Avenue Southeast, which is literally at the western edge of the hospital boundary at the High Point interchange area, which is a concern in that at this point, our whole neighborhood, which is about 75 homes, is approximately 2 miles from Swedish, 5 miles from here, but yet we're still paying the taxes to support the district, and it may be an issue that our neighborhood comes to you later with asking if it's feasible to be removed out of the district, because we really are half the distance to Swedish as we are to here. So I'm coming to speak on the merger and affiliation issue, knowing that I don't know all the details, but I'm hearing enough that I have some comments I'd like to make, and if they're wrong, I apologize, but again, I don't know all the details of what's being negotiated behind the doors of private meetings. But I am concerned about what I've heard of the situation. And let's just revisit what I know. The hospital district is $100 million in debt. Most of that, all of that, I believe, came before many of you were even involved. So I'm not blaming, I'm just acknowledging what I believe is a fact. And then consultants were hired to do an RFP outreach and engagement process with potential bidders for an M&A proposal, with an expectation that numerous proposals would come in, but I've heard only one did. And that one, coming from a faraway hospital, pretty well unknown, in Yakima, that's further distanced by ownership in Tennessee. And coincidentally, that same hospital happens to be where the former attorney for this hospital, Jay Rodney, now is employed. So it's a little coincidental and a little suspicious to me. And I would comment that if I were even going to re-roof my home or get new carpet, I'd certainly get more than one bid. I would ensure I would get more than one bid. And in the case of this situation, $100 million in debt, wanting to do the right thing going forward, I'm urging caution that we not go forward with just one bidder at the door, especially a bidder that's really got no merger and affiliation benefit that I can discern being over in Yakima. It's not like there's shared facilities. You can't refer someone who may be a patient here to go see the orthopedic surgeon in Yakima because they're just not going to do it. So it's something that really begs questions about why we would even want to do this. I don't see any network synergies myself. Moving ahead without more proposals and due diligence may make a $100 million problem enlarged, and that's what I'm concerned about. We're already paying a lot of taxes on this, I am, and I don't want to have to pay more. And I know you're all wanting to do the right thing to fix the situation, but I would urge again, even in my own, boil it down to a personal level, I was getting roofs, a re-roofing bid, as I did a few years ago. I got 4 or 5 of them, and believe it or not, the prices ranged from $13,000 to $8,000, and it took, I took advantage of that to get a better price. I'm urging you to do the same thing. Maybe rebid it, explore other opportunities, do some personal outreach to local groups like Overlake Swedish and others that you all well know, and let's see if we can do something better. Thank you.
Thank you, Ken. Is there any other public comment? I have, and this isn't fair to you.
I'll sit back now.
No.
It's gonna be-
No. It's just that it's 3 minutes and we didn't let Ken know, and I know he went over a little bit, so we'll give you some grace.
Sorry.
Oh, that's good. We gave 4 minutes.
We gave him 4 minutes, okay. 4 minutes.
Some of you, most of you know me. My name's Herschel Backus. I live in North Bend, and I've been attending these meetings off and on for 25 years. And with, I would say, mixed results. Generally speaking, decisions are made behind closed doors before we ever hear anything about it, other than rumors. For example, what I've heard about this affiliation doesn't pin it down to whether we're looking at a partner, or we're looking at a sell, or a lease. No matter what it is, who actually has the control over the purse strings of this hospital? Are we going to turn everything over and bow out of it, and we have no longer a say in it, yet we still have the property taxes that we're paying in and have been for years and years and years? I think that the public needs a little bit more input before we can make a determination. However, if you're going to make a determination without a semi model, just make it and we'll be drugged along with the for example, the $100 million debt. I doubt that Yakima Region is interested in picking up that $100 million debt. Are they picking up the assets of the hospital? Are they picking up all of the revenue of the hospital, spend it as they will? But they expect us to continue with this $100 million debt payoff. That debt, by the way, will never be paid in my lifetime. And I doubt if it's paid the way it's being paid now, it'll never be paid. If this happens, if this merger, this affiliation, whatever turns through, right now we are considered, or I understand, a non-profit hospital. Does that mean suddenly we're a for-profit hospital? Is there legal entanglements there that has to be considered? Mr. Spiker, the attorney, should be able to figure that out. Probably knows like that. I don't. If this goes through, and I have a little bit difficulty with going way back when this hospital was first put together. It was put together with these boundaries, with this system of nonprofit. Whether it goes profit or continues as a nonprofit, is the public who has been paying for this all along going to be able to vote up or down whether this affiliation is accepted? Or is this bothers me a lot. Well, you're just going to make this decision, turn over to, I didn't know there was somebody in Florida or someplace, I knew it was regional health. We just turn it over to them, we just keep writing the check for the $100 million, and we have no say in it all. I have a problem with that. And I also have a problem with only one offer that was made when this affiliation request went out. So you only have one. hang out till you get another one. Revisit that situation, try again, do something different. This was like, from what I've heard, the rumor has it, that this is scraping the barrel. This is bottom, this is the only offer you've got. I would hate to think that you're going to jump on this because we got no choice. We do have a choice. We've been staggering under this load and forever to jump on this as going to save us. It's not going to save us. Because we'll leave all the debt behind. It's not going to save us. I think that the very least, after you've made the decision of what to do, put the package together, stall long enough to ask the members of the public, the voting public, the one that owns this hospital, if this is something they'd be willing to do. And I think if it's not a legal requirement, I think it's at least a moral requirement.
Thank you.
Thank you.
Thank you. Is there any other public comment? Hearing none, we will move on with our agenda. First thing on the agenda is strategic and, oops, no. I've been told by,
I've asked if we could.
yes. Does any commissioner have a objection to switching 1 to 2 and 2 to 1 on the agenda?
No problem.
Okay. Hearing none, we're going to go ahead and start with the compliance update.
Thank you.
Okay, good evening. For those of you in the audience that may not know me, I'm Chief Daniel, the Chief Financial Officer of the district, and also performing the role of Compliance Officer. What I'm going to give is a Compliance Committee update. In the bylaws, it states that the board shall monitor the activity status and resolution of compliance issues as reported by the Compliance Committee. Reporting will be made to the board by the compliance officer. Yes, I am the compliance officer. Next slide. We have a compliance scorecard that we have shared with the board, just outlining what we measure to measure what we're doing in compliance. There's a number of programs, billing and coding audits. We completed an audit of our billing and coding procedures this year, and made some changes that we're recommending. Compliance training. 100% of our employees have been through compliance training, and we have offered and required compliance training updates annually to employees. To date, 82% of our employees have completed the annual compliance refresher course, and we have made that mandatory for all employees.
Do you want to wait till the end of your questions, or shall we ask them?
Why don't you ask them?
Well, how about defining compliance?
Compliance, good point. Compliance is the programs we have and the analysis we do that ensures that we are in compliance, operating within all applicable laws and regulations and norms for the healthcare industry. Does that make sense? Okay. It is a very broad look at our activities. So we'll talk a little bit about the programs we have in place and the activities.
I'm just curious as to how that pertains to new employees.
Well, what we want is, we'll talk about this, but every employee, I can't possibly see everything that's going on in the hospital. So we have programs in place that encourage and actually we ask employees to report on issues where they think we may not be compliant with law. So we give them training when they start and then put them through training every year as a refresher course. Because we want to know and we want to correct things. Patient information notices, we're monitoring that. Now I'm okay. All of our postings for our Human Resource Department are up to date. We have in place a contract monitoring system, so we verify that we have been receiving the contracted services from the contractor. It's out of our materials management area. We have provided risk management training to all employees, which is provided by our insurance company. And we annually review the Office of Inspector General work plan to see what issues are on the top of their radar screen compliance-wise. We reviewed the plan for 2017 and 2018 plan will be published. And then audits. We have had a number of audits this year. The CPA audit was completed in the second quarter of 2017. We had a state audit completed in the second quarter of 2017. We had a audit by the IRS called a 501R audit, and it audits our compliance with the provisions of the Affordable Care Act. That was completed in the third quarter. The HCA, the state agency, will be doing an audit of our Medicare payments for our Medicare, for our medical record system. That's a state mandate. It's still in progress. We had a review of our charge master. So the charge master is a system that controls our billing. So we want to make sure that we have it set up correctly and are utilizing it correctly. And every 2 years, we hire a consultant, an expert to come in and review that. Because if your charge master is not set up correctly and you're not using it right, it's big trouble. So we want to make sure we're billing correctly. And we are in the process of reviewing the new state law on sick leave to make sure that next year we be in compliance with that. It's effective 1/1/2018.
Does that include the family and medical leave?
Which includes FMLA, family medical leave. Third quarter activity. What did we do last quarter? We mentioned some of this. We had the 501R audit by the IRS. The audit was completed. There were no recommendations or findings. We're waiting for a written report that says that. I haven't gotten it, so I actually called the auditor this week and said, "Where's my report?" And she said, "Oh, I apologize, we're going to get it to you, but assuredly still no findings." So we're in compliance with the provisions of the Affordable Care Act. Charge master review, we talked about that, biannual, and we've completed all recommendations. Compliance training. 82% of our employees have completed their compliance training through yesterday. There is a requirement that staff must complete the training by the end of the year. And the compliance-related items within that review, there are a lot of healthcare patient care items, but there's training on patient rights and maintaining patient privacy. I'm going to talk a little bit more about maintaining patient privacy. The Washington State Sick Leave Law, Initiative 1433, passed by the legislature, requires us to give sick leave, allow all employees to take sick leave. Right now, we do not accrue sick leave for per diem employees. Those are employees that fill in for specific shifts on a daily basis. For part-time employees and for employees that work less than 20 hours, have a less than 20-hour schedule. The requirement is that we are going to have to provide sick leave to all these employees beginning January 1st. So we are working out the details for an implementation January 1st. And it seems simple, but it's really not.
Now, per diem employees are probably not just here, but in other locations. Is there a way to compile their sick leave credits between organizations?
There's really not. And the requirement is that we have to provide a bank, and we have to accrue hours based on their hours worked here. So there's,
So they may have split hours
Oh, yeah.
everywhere and they're really not be able to use them.
they can use it, but we have to work out the procedures where they can request it. It's a little bit different for the employee. That's why it's, I don't know.
Employers with how many employees have to follow this?
I believe it's 50, but don't quote me on that, but it would definitely fall within it. So. Okay. I'm going to talk about HIPAA, the health insurance, affordability, and accountability act. And within this act, it was implemented in the 90s, is a rule that requires us to maintain the confidentiality of patient information. And if patient information is inadvertently breached or disclosed, it's called a breach, a breach. And there's a breach notification rule. If we have a breach, we have to report it to the federal government. And generally a breach is an impermissible use or disclosure of patient information. So we monitor this.
Have we ever had a breach?
We have never had a breach, but we're going to talk about this. We have had reported incidents that employees say this may be a breach. So the district encourages employees to report potential breaches through our online quality reporting system called Safety Zone. And again, the reason that we encourage employees to report it is because no individual here has eyes on everything. So this allows us to then look at something and say, well, let's investigate this. And we do investigate. And again, we have determined we had 5 incidents reported this year. None of them were determined to be HIPAA breaches. But we still do the investigation, and we still will look at our procedures. Even if it wasn't a breach, it may indicate a procedure that we need to revise to actually operate better. It's really part of our quality improvement and compliance. Again, we had 5 potential events, none were determined to be breaches. That's my report. That's what we answered. Any questions?
Does anyone besides ourselves look at whether they are or not breaches? In other words, can we decide that?
Yes, we can, because there's a very, there's a decision tree you go through. You answer some questions and say, okay, this was not a breach. And it's looked at by the manager of the department and myself as a compliance officer. So we both look at it. Questions?
Any other commissioners have questions? Then we'll move on.
Thank you.
Thank you, Steve. Next on the agenda is our compliance update, and I think Superintendent Parker is going to do that for us.
So I just did that.
Oh, what'd you do? Oh, that's right, he switched them.
Yeah.
Yeah, okay. Strategical and tactical plans update.
So tonight I get to talk about non-affiliation strategies. We spend a lot of our time, and rightly so, talking about affiliation, but as we all recall, last year we put together a strategic plan. There were a number of strategies, and in order to make sure that as an organization, those strategies move forward, we rolled out these strategies to our management team, and we said to each of the department heads, identify specific tactics that you can work on in your department to support the strategies of the organization. One of the things that we hear so often about strategic planning is that we put together a plan, and then what happens with it?
It's out of date.
Well, yes, that absolutely is out of date. And while it's getting out of date, it's sat on a shelf somewhere. There we go. And, yeah, it's sat on a shelf somewhere. And what we wanted to do is make sure that our strategic plan was vibrant and and that we were looking at it regularly, and that we involved all of our departments in that plan. So we're going to test my dexterity here to keep our slides going. So in strategic planning, just as a reminder, we start with our mission, why we're here, who we are, what we're doing, and then after that we talk about vision, right? What do we want to become? And then after that we develop strategic focus areas and the definitions around those, and then we in management work on tactics. So this is just, you've seen this before, mission is who we are, why we're here, and it tries to mission-related core values of the organization. And then when you get to vision, we talk about being the healthiest community in the country, in the nation, that's where we want to go. And they're driven by those strategic focus areas that we all worked on in this room. So tonight, tactics. How do we move those forward? So just a reminder, 4 strategic focus areas. Can anybody quote them? Growth, financial viability, relationships, quality. Not in that order, because we actually said in this group which one we wanted to work on more than any other was making sure we were financially viable. Out of those 4 strategic focus areas, we put together 17 strategies. And out of those 17 strategies, the management team then put together 102 tactics. We'll be reviewing every one of those tactics tonight. That's not true.
I'm glad.
What I did, as you may recall, is I put together a tactical planning dashboard. And what you see here is now the results of the work of our management team and all of our staff in accomplishing their tactics represented in a dashboard form. So, and for some reason, there we go. I got the slides reversed a little bit. Here's the slide that should go first. We put together a method of color coding things in terms of how they're doing on their timelines. So green is they're hitting their timelines. Actually, going back, for my purposes, a light gray means the report is pending, which means I just got to keep hammering on folks until they give me the report. But white means that the timeline isn't such that that project is really due for an update. Green, they're hitting their dates. Yellow, they're about a quarter behind. Red, they're a couple quarters behind. And then some of the dark gray, we deleted tactics because things change over time. So we accommodated that as well in our planning and in our reporting. So again, these are the dashboards. I'm working on the dexterity here. Okay, here we go. First, what I'm going to do is I'm going to point out the ones, and you have these, but I'm going to point out ones where we're either yellow or we're red, and some of the ones that are green that we're especially proud of and I want you to know about. First one, and I'm just going down the list in terms of how they appear in my report, but in MedSearch, this one was to reduce the waste of supplies. And here's a pretty cool idea that staff came up with, and that is every time we discharge a patient, we go into the room and we gather up those supplies and we take a picture of those supplies and we list out what those supplies cost, and we educate all of our staff about what didn't get used and how much that costs. And it really helps to inform. You know, one of the things that was interesting, and I'll be getting to my Becker's report at the end of this presentation, but one of the hospitals started informing orthopedic surgeons about the cost of hip implants. And as soon as the surgeons learned about the differential and the cost of hip implants, they actually started to make different decisions. But they couldn't make those decisions without the information. They didn't realize that one implant was so much more expensive than another. Similarly, as we teach staff about how much things cost that don't get used, that just get put into a room, it helps. So what we've done is we've actually done 4 discharges now with this, and what we've done is we've provided the photographs and the cost estimate to our staff, and our manager of this department plan is to continue this in the 4th quarter and do more education around that. Next one is in nursing administration. We wanted to efficiently deploy paid staff hours
specific to our sitters. Now, just a reminder, what is a sitter? A sitter is a staff member that is with the patient in the room. I'm just going to get some water. She or he, thank you, is with the patient in the room, making sure that the patient doesn't do things like pull out their lines or have a fall. And what we realize is that we have a lot of sitter hours that we're continuing without us asking the question, well, do they still meet the criteria for having a sitter? And so our manager did a fantastic job put in place a new policy that's very much like our policy when we assess a patient for restraints. You can't just put a patient on restraints and then leave that there. You have to keep reassessing. So they did the same thing. And amazing reduction in the number of sitter hours by constantly asking the question whether or not we need to have sitters on this patient. They reduced sitter hours compared to 2016. This year, we're running at 1/3 of what we were in 2016. Great result. Okay, next one is the social work. This is around financial literacy, helping our patients to understand their future when it comes to what life is going to be like after they discharge from the hospital. They started out doing group workshops and realized that that wasn't really getting the results they wanted, so they went to one-on-one sessions, and this program seems to be really resonating with our patients, and they're looking at doing that really permanently now, and that is one-on-one sessions about patient financial futures. A lot of that's around the Medicare benefits and how to get the maximum out of that. Medical staff services. This is the department that does all the credentialing work that Dr. Rickett talked about in a previous work study session. But what's really important for us is making sure that when we have a new provider, that all of their information is loaded in and provided to the payers, the insurance companies, because until that happens, we can't bill for those services. And so they set themselves a goal to get that done. They said 8 weeks prior to their start date. That's really aggressive, and that's great. And they've been doing that. In fact, we're able to report that Q3, 100% of that time occurred. Now, we don't have a lot of new providers coming aboard, but when we do, getting this done quickly helps us to be able to get the revenues going on those new providers. In the lab, we talked about this just yesterday in medical committee. When it says C. diff, as you learned yesterday, that's just one of the tests that molecular testing is providing us. And so we wanted to bring molecular testing into the organization, send fewer tests out to reference lab. This reduces the amount of, this is really important though to the C. diff patient, because when, and I'm looking at clinicians because you know this better than I do, but when a patient is suspected to be infectious, we immediately have to put them on isolation precautions. And leaving a patient on isolation precautions is not fun, and it's not great for staff either. There's all this gown up and doffing of protective wear and gear, and just a lot of process around an infectious patient. So the faster we can know whether or not they actually are infectious, the better, and this allows us to do that. And Lab's done a great job of getting that in place, and I think we're going online in 2 weeks, actually. In the emergency department, as you all know, Trauma 5 designation was a huge goal for us. It was a mountain of work, especially for Chris Barnhart, our manager in the emergency department, but a lot of other departments were very supportive of that, and they had goals in that. And I just wanted to make one note before moving on this slide, and that's at the very bottom. The Department of Health was so impressed with the application that we provided that they have asked permission from us if they could share the quality plan and all the forms that Chris Barnhart developed for our application. Those are going out across the state, because right now is trauma renewal time for all the other trauma hospitals, and the state is sharing our quality plan with them. So pretty cool. Here's one that comes up in red. Our dietary department accomplished a lot of other really good things, and you'll see some later on. But one of the things that they haven't got done yet is they wanted to do a nursing survey. And I talked with our manager there in dietary, and he said, well, Tom, he said, we're working on it right now in Q4. We did have a few other things, and these were pretty good projects that they did because they saw them as really high priority, and that was, now this sounds funny, patient snack. Well, patient snack is actually really important because anything and everything that a patient eats while at the hospital, especially those patients who are on specific dietary plans, needs to conform to that plan. And if the snack part of their day is not conforming to that, they can go off on a medical tangent that our physicians and nurses don't want them to. So standardizing that process of who does what was really important. Meal delivery for isolation patients. Just think about it. How do you get a meal tray in and out of a patient room where the patient's on isolation? What does that process look like? How do you make sure that you're not spreading infection all the way back down to the kitchen? Well, they worked on it. That did a great job with that. As you know, put a gift shop online this year. That was under that team's, especially the manager's purview. Did a review on diet texture to make sure all of the foods going out of the kitchen were the right texture according to the assessment that had been done by the speech pathologist. And then finally getting our presence at the farmer's market this year, which we just started in the fall. So again, working on the design of that survey now in the fourth quarter.
Excuse me.
Yes.
Is that the north end or the Carnation Farmers Market?
That was the Carnation. So it's the first one.
So then we'll also north end.
Next year, I'll put that on the list for next year. Yeah. Okay, anything else? Maintaining a high level of patient satisfaction, and we have great scores. Our ED CAP scores in the emergency department. ED CAPS, that's the patient satisfaction score that all hospitals use in the country, and our scores remain top box scores all into the third quarter. In the lab, back to the lab, we wanted to reduce wait times for our outpatients. One of the things that we were doing in the lab was we would view the order on the computer system, bring up that order, sync it up with their past medical record, and then print labels. And now all that happened before we did the lab draw. What staff realized going through a process was that they could actually bring that order up, print the labels off of that order, and there would be the exact same labels, do the draw, and then sync that order up with their medical record after the patient had the draw. And it really has reduced the amount of time that a patient has to wait to get their draw done. And what I love about this one is you can see their goal was that it happens 95% of the time this way. They involved a lot of staff training to have the new process in place. You can see April 87, May 90%, June 93, and they're still reaching for the 95% with more staff training. But I love how they report that they started at one point and they're making the progress along the way. In med surg, working still. This is one that's yellow. Although it's kind of green, but we're still working to finalize this policy and get it taught by the end of the year. And that is discharge planning, and that is a coming together of our wound care program, pharmacy, and nursing to all help patients who are discharging who need ongoing wound care, and they're going to be doing some continuing treatment outside the hospital. So what do they need to know before they leave? So a lot of work and coordination so that the messages are all consistent, and everybody has a role there. The wound care nurse has a role, the pharmacist has a role, the nurses have a role, and make sure that's all covered.
We use the term there, med surg. I know that's a standard term.
Yes.
That we use, but we don't have a surgery.
We don't have surgery, but a lot of our patients are post-surgery.
So is that what's meant by med surg?
Yeah. Okay. Yep. It's a combining of medical patients and post-surgical patients. Yep. In patient accounting, one of the goals was to create a feedback survey regarding billing and financial counseling. Like dietary, they had a lot of other things that came before this on their plate. So they're working on this in the fourth quarter to create that survey. They did a lot of really good projects though this year so far through the third quarter. They implemented insurance verification software. That's huge for us. get it quickly verified so that we know that the hospital is going to get paid and the patient has the coverage with us as the provider. Implemented automatic appointment reminders. They did some restructuring of their staffing in the department. They're working on the Rural Health Clinic project. That's been actually going on for a while now. And they worked with the change that we made where Medicaid patients are now being seen in the hospital clinic. This was a huge change for patient billing as well. And then as Steve mentioned, we did our biannual charge master. So lots of things that they got done. Wasn't exactly the thing that they had set out for themselves, but they're still committed to it. In marketing, one of the things that we put on the plan for this year was to create an internal quality improvement report and in that newsletter. It's a newsletter that that describes all the quality activities, and we give it out to all of our employees. We lay it out here in the on the counter. We just make that very available to everybody. We did finish the third quarter newsletter, and we're now working on the fourth quarter newsletter. That is a quarterly occurrence. Clinical education, this is really cool. Nursing, maintaining our relationships, enhancing our relationships with nursing schools, with the high school. And our director of nursing, Rachel Weber, is on the Dean Advisory Boards for the University of Washington and Bellevue College School of Nursing. And in the third quarter, we trained 2 nursing students from Lake Washington, 1 from Bellevue College, 1 master's level in nursing from Simmons College, and 1 bachelor of nursing student from Indiana State. And we've actually had hires come out of this training. And this is just a little glimpse. This is not all the training we do. Dr. Wickup, what's the number of students that we have this year so far?
75.
75 students here in the hospital. So our staff has been very involved in helping the next generation of caregivers get the training that they need. And then for the fourth quarter, we're working with the high school. We're going to have 8 students from outside high school doing a shadow experience to get them energized about doing a career, having a career in healthcare. Back to marketing. We wanted to promote outpatient rehab and imaging, and we did that in a couple of ways. One is the door-to-door campaign, which we've talked about here before. I'm happy to report that we not only hit our goal of 500 homes this year, but we doubled that. We hit 1,000 homes this year. So pretty impressive work by that campaign.
Is that in a span of 2 months, 3 months? I remember
that was
in March when you
we did it in
started.
different phases through the year,
okay.
so yeah.
That was all on Snoqualmie.
It was on
Right.
Snoqualmie Ridge. That was our first marketing area for that campaign. Correct. And that was, of course, getting marketing materials, which included rehab and imaging. And then our directors in those 2 areas, Jim Stussel for rehab and Ron Bennett in medical imaging, have been out in the community making visits to providers to educate them about the services that we have to offer. And we started to see the results of that work. Imaging volume has been pretty good as of late. And outpatient rehab, which has struggled for reasons we've talked about before with location, but last month had a big influx of new patients into that program. Now, I will say 1 data point is 1 data point, 2 is a coincidence, and 3 is a trend. So we're hoping to break through 3. Okay, in dietary education, these are our clinical dietitians. They worked this year with Mount Si Senior Center lunch program to get them to the point where they had a full, predictable, rotating menu, and that's been done. They also worked with them so that they would have the resources that they needed in order to understand the nutritional facts about the food that they were serving there. They reviewed all the menus with them and helped them with that. And then next year we're going to, or actually this quarter, working with Snow Valley Senior Center to do the same thing. But that full rotating menu is in place. Also on marketing, we wanted to promote our new provider in the clinics. And so we did that through our some advertising and promotions on the website of our new provider, Julie Wood.
She's a geriatric physician, is that correct?
No, actually, she does a lot of great work with teens.
I just see her focus advertising on geriatrics.
So Jillian Rippey was not geriatrics, but fourth quarter, what we want to do is now, the next step to help with clinics growth is emphasize our capabilities in geriatrics. Thank you for that question. Okay, that's the over. That's 15 of the initiatives. If you have questions about others, please give me a call, but we just can't go through 102 of them in one session. Yes?
I know the board has talked about potentially, at some point maybe, just hypothetically, looking at bringing in additional physicians for outpatient procedures, some kind of a group. I think we had talked about in strategy sessions. Do we have any kind of procedure that that we might be looking at, and how we go about doing that, and some kind of a plan that we can understand as a board then?
So outpatient procedures would be procedures that we're not currently doing.
Yes.
And so what we have, so that one is back to affiliation, where we said we wanted to work with an affiliate partner on expanding the scope of services. So we put that into that bucket rather than trying to create that on our own, because the capital expense was.
Yeah, but as the board has not made any decisions, and we don't know if we're going to go forward or not, so it's probably best if we have some kind of a backup kind of plan available to be able to implement something like that if we had to.
Yes.
So, obviously this is a work study session, but I'd sure like to have this for some kind of brainstorming here for our board to discuss with the staff on. I know I've been mentioning it quite a bit lately, and there's been some public comment saying we've got only one proposal. There's a lot of reasons and a lot of different, I could comment a lot about straighten some of the information out, but one of the things I think would be prudent to do is to have this plan B, start, at least develop that plan and get it ready in case we have to fall back on that. And that's something I thought that would be really helpful, even for leverage or anything else if we're going to be needing some of that. So don't request a vote or anything. I sure would like to have that as soon as possible for the board to discuss, at least for you to give a little presentation of some kind of a plan that encompasses something like that. So.
I saw an attractive brochure at the Snow Valley Senior Center from Evergreen, and it said your rights as a patient. Do we have an equivalent brochure?
Absolutely.
Yeah, that's very important.
Yeah, we do have a patient rights brochure for them that lays out their rights very clearly.
If there are no other questions?
I have another section that I wanted to review, and I know this is not necessarily tactical planning, but I had the opportunity to attend the annual meeting of the Beckers organization, and that was a great experience. I hadn't been for a couple of years, and being able to hear what other hospitals are challenged with makes me realize that regardless of size, and I've got a number of quotes here, and you've got them in your packet, of CEOs of hospitals and systems. I mean, we're talking about systems that have revenue in the billions of dollars. But the reality is that the issues that they face are faced by every hospital in the country, especially as it deals with anything that's regulatory or the shifts that are occurring in terms of payment reform. We're all dealing with it. And so I wanted to bring back some of the impressions that I had attending the Beckers conference, and I've grouped them all together into a number of areas. The first one is this shift to value-based care and payment reform. Lots of talk about that. Especially interesting this year was how many hospitals have said, we've turned the corner, meaning they have stopped thinking about keeping their hospitals full, and now think about trying to keep their hospitals empty. And why is that? Because they're getting paid on a per member per month basis for enrollees in value-based, affordable, accountable care organizations. So they're starting to act like an insurance company, and they're realizing that when the hospital is full, they're spending money that they're not necessarily getting revenue for.
Tom, how does that relate to what I understand is a cancellation of the bundling?
Yeah,
Which it seems to me that was the backbone of value-based care.
it was a component. I would call it a component of value-based care. It was one of the programs that was coming out of CMS's Innovation Center, and there were a number of new payment experiments that were coming out of the Innovation Center. Bundling was one of those. And what's happened is that the HIP and knee bundle goes on, but what you're reading about was the proposed there's a proposed cardiac bundle, and that one sounds like it's dead at this point. So there are some
Cardiac arrest, we could call it.
Okay, so there are some changes in Washington that are kind of pushing against a little bit some of the changes in payment reform. But what I heard at Becker's was that independent of that, it continues, especially now we're seeing it on the commercial side as well. And how the federal government pays for Medicare is kind of irrelevant to what's happening in the commercial market. I heard a number of good presentations on organization culture, regional strategies, and affiliation. Lo and behold, there are other people talking about affiliation, and then people talking about what it's like after affiliation, how to run a good system, how to be integrated. There's a couple sessions that I came on that, and finally on health policies. By the way, there was one session I didn't take as good notes as I should have, because I was just thoroughly entertained. It was Howard Dean and Rudy Giuliani together on the stage in a discussion being facilitated by Scott Becker. And Scott's a pro at this, and I can tell you it was the most entertaining session I've been at in years. And listening to those guys who really get along, but don't always see eye to eye. And I wish I had recorded it for all of us, but anyway, just that was it was a privilege to be able to watch that. So let me just jump to some quotes here. Akram Lucas, who's a physician and CEO at Metro Health in Cleveland, said, "With respect to the shift to value contracts and narrow networks, half our margin now comes from risk contracts." Half their margin. That's huge.
What is a risk contract?
A risk contract is where you get paid based on hitting certain volume or actually cost thresholds and quality thresholds. So if you don't hit those thresholds, you don't get paid. And so they're seeing that their revenue is tied to being able to prove that they're getting the balance. Barry Arbuckle at Metro, and I can provide you any background on these organizations, but just suffice to say, these are big organizations. So you can't wait to change your infrastructure to support value-based care. Some are saying they will wait until the preponderance of business is in value-based agreements. At that point, he says you're years too late. I want to applaud Dr. Wickup for helping our providers understand the importance of the measures that we're tracking. Dr. Wickup has prepared our providers for living in a value-based world by letting them know these are the measures that we're all going to be held accountable for in this value-based world, and exposing them to them, showing them how they're doing on a regular basis, and getting them ready for those kinds of agreements. Now, for example, within the EHN network, we have contracts where we're not at risk for them, but there is encouragement to do well on those indicators, and we share in that motivation with all those who are in the EHN network. Next quote, Nancy Heller from Christus, huge system in Louisiana. "We are seeing a commercial crowd-out effect This is demographics that we're moving to government payers, especially with the aging of the boomers. So for the next 10 years, as we see boomers age out of their jobs, going into retirement, well, guess what else is happening? They're all moving into Medicare. So that pool of folks who are going to be in government-initiated value-based contracts is going to continue to grow. Okay, on organizational culture, a couple quotes I really love. This first one, CEO of Carolyn Clinic, and she happens to be the chairperson-elect for the American Hospital Association. She said, be mission-driven and data-informed. I thought that was a good thing. And we are. I think we do a pretty good job of that. We try to bring data. This one made me smile. CEO of Oregon Health Sciences University said data before drama. So put your emotions aside and really just focus on real facts. I like that. Again, Akram from Metro Health System in Cleveland said, strive to wring politics out of your organization. That way you can focus your energy on doing good work and move quickly because you trust each other. And then CEO from Riverside Medical Center said each person, that's New York, if I remember correctly, each person has to operate as a member of the team. Each member of the team has to put their individual goals aside if they conflict with being part of the team and pushing team goals forward. So we don't need one thing. Okay. On affiliation considerations, Andrew Mitchell was the CEO of a hospital in New York. He's been through pre-market affiliation deals himself. And so he had a couple quotes here that I like very much. The first one is, the process is almost as important as the outcome. Second, if you are a smaller entity, be careful of lining up with a hub and spoke model. You don't want your partner to have the expectation that they'll receive all your patients. And then Joseph Lupica, he is a consultant with Newport Health, and they're a national company. They have offices all across the country, and they provide consultation similar to what we are receiving from Hebner and Cave. And they have put together hundreds of deals, and they said, always be in favor of good process. Don't prejudge the solution or the deal. And kind of back to look at your data. He said, no, this was great, because I felt like we had done this right. He said the criteria for the deal is good for evaluating a potential partner, but it is critical to know about yourself. What he said is, as you go through and you put together the criteria for what you want to accomplish, you're learning about yourselves. He said, document it in stone, and you've done a good job of that. He said, because you'll come back to it. He said, you will learn about their culture as you go through your due diligence, and that's what we're looking forward to, is learning more about a potential partner here. He said, consider partnering with someone who's just far enough away that they won't suck out your local business. And then don't start talking to anyone until you know what you want. Don't put yourself out there, just have dinner with them until your objectives are clear and documented. We did that. We went after knowing what we wanted. Lastly, second to last, on being a system. This is after a deal is done. CEO of Carolyn Clinic said, and Carolyn Clinic is not just a clinic, it's like Mayo Clinic, it's hospitals and clinics. And Patrice said, take care that you don't value the processes of your larger hospitals as having more value only because they come from a larger hospital. Look at processes that deliver better outcomes and study them as to whether they can apply across all hospitals, and then figure out if you can scale them up or scale them down. This rang true to me, not so much for us, but my experience that I had working 14 years in Legacy Health System in the Portland area, where I was administrator of a 120-bed hospital that happened to be the smallest hospital in the system. And we were sometimes, the ideas that we developed at Mount Hood Medical Center were not given the kind of weight that I thought they should have been, because it wasn't coming out of a manual. It's American Hospital, a 350-bed hospital. So I love James. Okay, James Crosby at St. Joseph in Chicago said, be serious about systemness, make hard decisions about things that you should not be doing. And the way it said is when you're a system, sometimes it's really hard to really dive in and see, because you're big now. One of the things that we thought at one time was a great idea, but you know what, it doesn't make so much sense. He said, keep looking after that. I had a CEO that I worked for, actually at a manual hospital, who said, we're like that stack of pancakes. He said, we're not very good at going 3 layers down and pulling one of those out. He said, you got to be able to do that. Okay, last one, health policy. And this kind of summed up the sense of the room. And there were hundreds of people there, but this quote I love so much. And she said, she's CEO at Marshfield Clinic, and she said, we're worried about the politicians' lack of concern and empathy for people and the healthcare needs that they have. And I think that, well, and that resounded well in the room. That, and there was a session on this specifically about politics in Washington, D.C. and the fact that the things that are important to the folks in Washington, D.C. are really mostly just important to the folks in Washington, D.C. And there's very little breaking of that bubble and understanding what it is that we deal with. And people had desks they were counting on and affirmation of that comment. So once again, I want to just say thank you for your support of me being at Becker's. I feel like that it enlightens me, it enriches me with what's going on in the country, and I brought a little bit of that to you.
Could you say a little bit more about who Becker is?
Yeah.
How well they're respected in the industry?
Scott Becker is actually an attorney, and he started Becker's Healthcare. It started with Becker's Law, and I think there was another industry, I can't quite remember. But about 7 or 8 years ago, started Becker's Healthcare, recognizing the need for being a convener of CEOs across the country to share information. And I'm glad you asked that question, because 2 years ago when I went to my first Becker's conference, I went in and I was a little stunned by what I saw there and what I didn't see there. I was used to going to a conference and seeing somebody like me, doing a PowerPoint presentation and trying to convey to a group. And Becker's has some of that, but well over half of the sessions is just tables like these lined up, and you've got 3 to 5 CEOs in a facilitated conversation about a specific topic. And so you're getting real-time information right from your peers. And I love that. It took me a minute to understand that that's what it was all about, but it was just rich information coming from folks who are dealing with the same issues that we deal with. And I try to take a lot of notes at those meetings because it's like gold. So Scott Becker does a great job of pulling all those folks together. I will say that he had on his advisory board the publisher and editor of Modern Healthcare for a number of years before he passed away back in May. So yes, high stature organization at this point. Yes, David.
So, doesn't he produce that bi-weekly newsletter that I get we all get, and it has a lot of interesting things and what's going on. Usually the first part of that is some hospitals going under.
Yeah.
That's
very encouraging.
And it's very true. And the thing is, if you just look at that and don't read further, you're not going to learn why.
Yeah.
You're not going to learn what you can learn to avoid something like that. But going back to that affiliation part of were they talking in terms of the reasons for affiliation, or was it just the process? It wasn't like we're seeing more and more entities affiliate to get to be a larger system so that costs are brought down and we can bundle our care and lower payments.
That was assumed. The value of affiliation, they spent very little time on that. They did mention economies of scale and being able to weather what's coming with value-based contracts and being able to do that, manage those contracts as a larger system as being an advantage. But then they quickly went on to, okay, you've you've seen that there is a need for you to connect and affiliate. Here's some of our advice about how you do that.
So are you seeing, like, when I'm reading these mergers and everything in the Becker's newsletter, it seems to me that these entities are getting bigger and bigger. The systems are getting bigger and bigger.
Yes,
Yeah.
this is true.
And that you hardly see anything about, the only thing I ever see about standalone small organizations is they're going out of business.
Yeah.
And that's all I've read in Becker's for the last year and a half.
Me too.
So-
I read it this way.
What's your read on Washington area? Let's not involve
Washington State.
Washington State.
Um,
Where is the state? Maybe you don't have an answer
Well, I
specifically.
do. I've had an opinion about it for a number of years. And that is that, especially the Puget Sound area, was about 10 to 15 years behind the initial systemization, meaning the creation of multi-hospital systems across the country. Seattle area hospitals were able to continue to operate as standalone hospitals a lot longer than anybody else was able to do that in the country. I don't have an opinion about why that was possible. We know the Puget Sound area is a fairly affluent market, and I would imagine that hospitals felt like, I don't need to affiliate, we're doing just fine. Whereas in lots of other markets across the country, we saw systemization occurring.
I would say too, a lot of the local hospitals have long year presence in the communities that they've been in. I mean, some of them almost 100 years. I mean, they're hospitals that have really been established and gone through slim times and prosperous times.
But now, Seattle has caught up.
Yep.
And so the Puget Sound area has definitely, in the last 10 years, gone from a few hospital systems to nearly every hospital in some kind of system. And if not system, definitely an affiliation. So hospitals like Boulder Lake, that's actually a rarity now in our market.
It's like the automakers, they're all, I mean, you've got an American cars with,
Parts from Europe.
Japan motors and everything.
Some of these affiliations and mergers are not apparent. For example, Swedish Lysekil is actually Providence.
Yeah.
In
Yeah.
terms of
Right.
finances and control.
Right.
And
So
so,
they kept the Swedish name because
They kept the Swedish name.
that name has brand value, so they kept that, but they are definitely a profitable organization. Yes, correct.
Yeah, it seems like with all this new development that's happening, the message seems to be clear that there's more encouragement to partner, that no hospital can stand alone.
Yeah, there are lots
That
of.
there's more of that.
Yeah, there are so many advantages, and we've talked about those, of being part of the system and being able to consolidate some of your operations, but having economies of scale so you can buy your supplies at a lower cost. You can, if you bring together 4 hospitals into a system, now you can take a little bit from each in terms of a little bit of cost and bring that together and create system-wide resources. For example, I don't think there's any way that we would ever be able to have an organizational development department, that provides staff training and helps people to improve their skill set and how they work in the hospital. But systems almost always have an OD service. That's just an example of the kinds of things that you can do as you pull together a little bit of resources for each member.
It's like the hospital industry is a little bit late on that, but if you look at commercial, private institutions, corporations, they've been doing many of these systems for many, many years. And so I think we're just kind of catching up right now with all that's happening.
And moving from that cottage industry independent model to being part of systems.
I remember the quote though that you showed us, which is essentially process is as enforcement as well. And so to me, that says you must convince the people that this is a good thing to do, that it was done openly, and so forth. Otherwise, they won't come. Even though you could build this beautiful system, but if they don't trust the process, they won't come. Thank you for that. Other thoughts? Okay, thank you.
Thank you.
Thanks. Thanks, Tom.
Good information, Tom.
Nice presentation.
No, not restricted, just have a bunch of slides on it.
We now have public comment time. Does anybody want to make public comments? Hearing none, then we will move on. Our next upcoming board meeting it's a regular meeting, is December 14th, 2017 at 6:30. It will be in this location. We have a work study on January 24th, 2018 at 6 p.m., also in this same location. Do I hear a motion
I
to?
move adjournment.
Is there a second? Second. All those in favor, any discussion? Hearing none, all those in favor say aye. Aye. Opposed? We are dismissed.